Didn't realize you were still here.
I'm just about through.
Is there an instruction manual?
That's it. Have fun.
Computer on.
Chart dictation program primed. Please select a patient.
Carolyn Collins.
Ready for dictation.
Patient has a smoking history of 30-pack years. Chief complaint, 3 days of worsening productive cough with increased sputum purulence. There's mild shortness of breath at rest, worse with exertion, and a low-grade fever. HEENT exam is normal. Lungs were hyperresonant to percussion, consistent with the patient's long-standing chronic bronchitis. Scattered bronchi present. Cardiac exam, regular rates and rhythm, and normal S1 and S2. Assessment, bacterial exacerbation of chronic bronchitis.
Would you care to review the likely pathogens? Such information has direct bearing on antibiotic selection.
Well, of course it does. But I'm quite familiar with the bacterial causes of...
Common pathogens responsible for bacterial exacerbations of chronic bronchitis include Haemophilus influenza, Streptococcus pneumoniae, and Moraxella catarrhalis. Many experts recommend beta-lactams or macrolide antibiotics as treatment.
Well, hold on. When treating Moraxella catarrhalis, I would hesitate to use cephalosporins. Over 90% of all isolates produce beta-lactamase enzymes and may be resistant.
Your files are clearly up to date, Doctor. May I add that there is a growing incidence of H-flu resistance to some cephalosporins. In addition, beta-lactamase-producing strains of H-flu would not be susceptible to amoxicillin.
Well, yes, I'm aware of that. Does your system have access to the most recent data on newer macrolides?
A moment, please. A nationwide survey of antibiotic in vitro susceptibility showed that only 63.1% of H-flu isolates were susceptible to Biaxin. However, a significantly higher percentage, 95.7%, were susceptible to Zithromax, azithromycin.
Interesting. Was the additive activity of Biaxin metabolite accounted for in that study?
Indeed it was. Still, a significant difference was noted between Zithromax and Biaxin. These data suggest Zithromax as an excellent choice for this patient.
Right, but not only because it provides coverage for H-flu, it's also effective against the other pathogens I mentioned.
I find that a picture is worth 1,000 words, and here are the numbers. As you see, in a recent study of patients with bacterial exacerbation of chronic bronchitis, Zithromax demonstrated high rates of clinical response and bacteriological eradication of H-flu, strep pneumoniae, and M. catarrhalis.
Exactly. That's why I felt confident about prescribing Zithromax Z-Pak for this patient. Shall we return to my chart dictation?
Of course. Although we have barely scratched the surface of my infectious disease databank, I also know a lot about microbiology. Would you like to try me on some in vitro data?
All right. What is the relative in vitro activity of macrolides against gram-positives and atypical organisms?
Against gram-positive pathogens such as strep pneumoniae, although MICs may differ slightly, all of these agents are highly active, with susceptibility rates in the range of 95%. In addition, all of these agents are highly active against Mycoplasma pneumoniae, with extremely low MICs.
Okay, Mr. Chips. What's the latest on drug interactions with macrolides?
Cross-reference, please.
Why don't you start with Seldane?
Warning, warning. In rare instances, terfenadine can be potentially cardiotoxic. Terfenadine has been associated with prolongation of the rate-corrected QT interval, which may predispose to the serious arrhythmia known as torsade de pointe. Usually, terfenadine levels are not measurable in blood, as the parent compound is rapidly metabolized. However, hepatic dysfunction or certain interacting drugs can adversely affect terfenadine metabolism.
Well, you're on the right track. Studies indicate that co-administration of either Biaxin or erythromycin can affect terfenadine pharmacokinetics.
Correct.
But you're missing an important point. Were you aware that 2 controlled studies have shown no evidence of drug-drug interactions between the macrolide Zithromax and Seldane?
Zithromax? Seldane? This is an important fact. I am now updating my drug interaction table accordingly. Thank you. Studies have shown no evidence of Zithromax interactions with Seldane, theophylline, warfarin, Tagamet, or AZT.
Can we return to the dictation of Miss Collins now?
By all means.
Plan. I advise the patient to quit smoking, and I prescribed a Zithromax Z-Pack, taken once daily on an empty stomach for 5 days. This course of therapy is a definite advantage of Zithromax. What your opinion?
I agree. Dosing with Zithromax is an advantage, especially when you consider that non-compliance with antibiotic therapies can be quite high. Up to 10% of all hospitalizations are the result of non-compliance with medications.
Did you consider adverse effects?
While the most common adverse effects of Zithromax are diarrhea, nausea, and abdominal pain, in clinical trials, fewer than 1% of patients discontinued the drug because of side effects.
And the cost?
Zithromax is less expensive than many leading branded antibiotics based on average wholesale price.
Correct.
So, in this setting, for efficacy, confidence, and convenience,
Zithromax.
Zithromax. Would you care to continue dictating patient records?
Gee, I don't know.
Doctor, I have already begun to adapt to your clinical style in order to enhance our efficiency.
Okay.
You know, Doctor, this could be the beginning of a beautiful friendship.